So going straight to the talk, this patient is a 65-year-old male. He's been coming with back pain since the last 2 months, and now he started having difficulty in walking as well. Although his power is normal, he started getting gait instability. This is what his X-ray looks like. And now later on, now this is what the MRI looks like. So at this stage, if you see this amount of collapse, you would start thinking that, oh, should I do a vertebroplasty or should I do a fusion? In this case, we went for a fusion in this patient, started having gait instabilities. And because the bone quality was quite poor, we have put in 2 levels above, below, and done a cementing at this level as well. I was very happy with this with the patient getting up and starting to walk the next day itself. But he did well for 6 weeks and comes back after 6 weeks with this kind of a picture. And immediately my thought goes that, oh my God, this is an osteoporotic spine and now the screws have cut off. But now I have put in very good screws, but maybe the bone quality is not good enough. So I got an X-ray done and this is what you see. No matter how good a fixation I do, the spine is still osteoporotic and the level above now when goes into a fracture and a proximal junctional kyphosis. So these are the kinds of problems that you deal with, and now you have to rely on things like a heart shield to maybe do a revision in a case like this. So these are a lot of consideration that you have to take in these osteoporotic spines whenever you are doing an instrumentation. Now, if we are going to consider, what do you need to see when you treat these patients, when you want to put in your implants? The first thing is that you got to check if there's T-scores. Now, if a patient who's got 1.5 to 2.5 range of T-score is probably safe and you can easily do an instrumentation without having much problems. But if you start getting a T-score of 2.5 and below up to 3.5, now you start worrying, okay, oh my God, now if I put in a screw, it is going to get cut out. And so I may have to use some jugaad, use some augmentation, etc. to make sure that this does not happen. And if it is less than 3.5, then the chances of this happening is very high. And it may probably be better to wait and treat these patients with teriparatide for maybe 3 to 6 months and increase their bone quality before you go ahead and operate, if it is possible, if it is clinically possible. Then this is not the only consideration. You also have to see what the type of fracture is. Now, if it is in a junctional area like a thoracolumbar fracture, now those are very high stress areas, and in those cases you have to think over fusion. You have to think about instrumenting more because they are, there's a very high chance of failure implants for there. And then the degree of instability. So if you've got a fracture like this one where the instability is very high, so again you're worried that just a posterior screw may not be able to hold very well. And do you need to maybe augment it? Maybe you need to do a anterior stabilization as well. So overall, when these patients, whenever we go ahead and operate on them, there are multiple considerations. So when you treat them, the medical management of osteoporosis, as has been said earlier, is very important. One additional point which I wanted to make was that maybe, we should probably try to avoid using anti-resorptives. Although this is controversial, but if there is a fracture and you are stabilizing it, there is theoretically a higher chance that the fracture may go into a non-union, or the union may be delayed if they are on anti-resorptives. And it may probably be better to use teriparatide in these cases, which have shown to increase the rate of unions and give you better bone quality. In instrumentation, whenever you use pedicle screws here, that there is always a chance of screw pull out or cut out. So how do we prevent that? You need to use bigger screws, wider screws in these patients. You need to use longer screws, maybe get bicortical purchases as well. Also, the screws where you have your dual threaded screws, which have a cancellous type of a thread in front and a cortical behind, works better than your normal pedicle screws. There are coated screws as well, like hydroxyapatite coated screws, which theoretically are better, where there may be some bone growing into the screw, so it helps to hold better. And also double screws have also been described in literature in these pedicles. So you can use 2 screws in a pedicle, which I personally have never performed. The other points which you can do here is that you can keep your midline structures intact. If you are only stabilizing them and you don't have to really do a good neural decompression, you can keep the posterior midline structures intact, and that may help to give you more stability and augment your fixation. If your anterior structures are quite unstable, you may add an anterior stabilization as well. You can use cement screws as well. Again, these screws are supposed to have a better pull-out strength. However, their use is slightly controversial because there are disadvantages to it as well. There is a higher chance of infections, and it makes the segment quite stiff. So the chances of adjacent level fractures are also higher with these screws. Again, controversial, not yet there's not enough evidence for or against it. You can augment them with laminar hooks or also wires, which has shown to increase the hold by 50% or more. Expandable pedicle screws also help a lot in these cases, although they are not foolproof, but this is something which people are looking at now. And then finally, you have things like the heart shield and sublaminar wires. Again, this is not foolproof, but the lamina is the last to get affected by osteoporosis. So the hold in your lamina is probably better than the hold in your vertebral body. So these kind of stabilization systems will give you a controlled collapse and will prevent it from going into kyphosis. However, they are not very strong in their rotatory forces. In conclusion, this osteoporotic fractures and their treatments is not just a surgical issue, it's a medical issue as well. And you need to consider various factors before you go ahead and finalize your plan of management. You need to take into account the degree of osteoporosis, the degree of instability, the degree of how much you need to fuse, and whether it is a junctional spine or not. Thank you.